My name is Sidel Case, and today I'm presenting my Capstone project titled Implementation of Music Therapy as a Non-Pharmacological Pain Management Strategy in Hospitalized Pediatric Patients. There's a sound that you never forget in pediatric nursing, the cry of a child in pain. It's raw, it's desperate, and it stays with you long after you've left the room. We give the medications, we follow the protocols, but sometimes, even after we've done everything that we can from a medical standpoint, that pain and the fear that comes with it is still there. For children, pain isn't just about an injury or a procedure, it's about being in an unfamiliar place, not understanding what's happening, and losing a sense of control. This project is about asking a simple but powerful question. What if we could help children manage both the physical and the emotional effects of pain without adding more medications or side effects? The answer I found was in music therapy. Structured, individualized, evidence-based, and designed specifically for pediatric patients. My capstone has a clear and measurable goal. Implement structured, individualized music therapy sessions for hospitalized children aged 5 to 12, aiming for at least a 30% reduction in self-reported pain scores within the first 24 hours of the intervention. We'll measure pain using the Wong-Baker-Faces pain scale, which is developmentally appropriate and easy for children to understand. The project also uses observational checklists to track engagement, such as eye contact, facial expression, body movement, verbal participation, and caregiver and nurse satisfaction surveys that capture the broader impact. By gathering both quantitative and qualitative data from multiple perspectives, we'll see not only if music therapy works, but for how and for whom. The 30% benchmark is based on research by Adeboye and Lowy, showing meaningful reductions are achievable when music therapy is well integrated. And because it can be delivered by trained nurses or child life specialists, it's low cost, adaptable, and sustainable for mid-sized hospitals. Anticipated results include lower pain scores, higher engagement, better satisfaction, and reduced reliance on PRN medications, creating a measurable improvement without adding costs or risk. Pain management in children isn't just a clinical responsibility, it's a moral one. And yet, despite our best pharmacologic tools, there's still a gap between what we can measure in a chart and what a child actually experiences during hospitalization. Pharmacologic interventions like acetaminophen, NSAIDs, and opioids can reduce pain intensity, but they rarely address the fear, anxiety, and emotional distress that come along with being hospitalized. We know from literature that these emotional factors directly affect pain perception. Harvard Health explains that anxiety and stress amplify pain by triggering the release of cortisol and other stress hormones, which then increase the brain's sensitivity to pain signals. Two children with the same injury can report very different pain levels depending on their emotional state. If we're only treating pain as a physical symptom, we're solving only half of the problem. That's where non-pharmacological interventions come in, approaches that target both the mind and the body. The Keck School of Medicine highlights how non-pharmacological interventions can reduce the need for sedatives and opioids in pediatric patients, helping to avoid side effects like sedation, constipation, and respiratory depression. Avoiding these side effects can mean a child is able to sit up, interact, and even play during recovery instead of being drowsy, withdrawn, or uncomfortable in new ways. One of the most promising of these interventions is music therapy. But I'm not talking just about playing music in the background of a hospital room. I'm talking about structured, individualized sessions designed to match each child's developmental age, preferences, and current emotional state. Music doesn't just engage one part of the brain. It activates multiple networks simultaneously, including the limbic system, which is involved in emotional regulation, and the brain's pain modulation pathways. Listening to or engaging with music can release dopamine associated with pleasure and reward while lowering cortisol levels. The result is a measurable shift in both mood and pain perception. The setting for this project is the Pediatric Intensive Care Unit at Eastern Idaho Regional Medical Center, a mid-sized hospital in Idaho Falls, Idaho. I chose this location because it provides a steady flow of pediatric patients, making it possible to implement and observe the intervention with a sufficient sample size. The staff already includes pediatric trained nurses and child life specialists, so the infrastructure of delivering non-pharmacologic interventions is already in place. The hospital size makes it a realistic model for other mid-sized facilities. The participant group will include approximately 20 to 30 pediatric patients aged 5 through 12 years old over an 8-week implementation period. These will be children experiencing acute or procedural pain, including examples like post-surgical recovery, fracture care, or invasive diagnostics. This intervention consists of structured, individualized music therapy sessions delivered by trained pediatric nurses or child life specialists. Music will be tailored to the child's age, preferences, and cultural background. Research suggests that patient-preferred music enhances engagement and therapeutic effectiveness. Some children may respond better to upbeat, familiar songs, and others might respond better to slower, more calming pieces. Sessions could be live, but the plan is to use pre-recorded structured delivery that is intentional. Even with the recorded music, facilitators will engage with the child before, during, and after to maximize therapeutic benefit. Sessions will be scheduled twice daily before anticipated pain triggers like dressing changes or IV starts, and in response to real-time reports of pain or anxiety. Pain will be measured before and after sessions using the Wong-Baker Faces Scale. Engagement will be tracked using observational checklists adapted from Redding et al., noting eye contact, facial expression and rhythmic movement, verbal participation, and relaxation cues. Caregiver and nurse satisfaction surveys will provide both quantitative scores and qualitative feedback. Our primary measurable outcome is pain reduction, and using the Wong-Baker Faces Pain Rating Scale, we expect to see at least a 30% reduction in self-reported pain scores within 24 hours of starting music therapy. This is not just statistically significant, but clinically meaningful, significant enough for the child to feel a real difference in the pain and comfort levels. Loewy's research shows that music therapy, when tailored to patient preferences, can lead to immediate decreases in pain perception in hospitalized children. Adeboye and colleagues found that pediatric patients receiving musical interventions alongside standard pharmacological care reported substantial drops in their pain scores compared to those receiving medication alone. In practice, this could mean moving from a score of hurts even more to hurts just a little. The second anticipated outcome is increased patient engagement. The literature consistently supports this expectation. Noble found that children involved in music therapy demonstrated better emotional regulation, more willingness to cooperate during their procedures, and improved overall mood. Redding et al. Showed that their behavioral cues such as rhythmic movement, smiling, or making eye contact increased significantly during structured music interventions. In our project, a child who might initially avoid eye contact or lie tensely in bed could, after music therapy, start tapping their fingers, swaying slightly, or engaging in conversation with staff. We expect engagement scores to more than double. The third outcome is higher caregiver and nurse satisfaction. In pediatric care, pain management isn't just about the patient, it's also about the people caring for them. Caregivers feel more reassured when they see tangible, non-invasive comfort measures being used. They feel that their child's emotional needs are being acknowledged, not just the medical ones. Nurses also report that music therapy creates a calmer environment and reduces patient resistance to necessary interventions like medication administration or wound care. These projected results have meaningful implications. Hospitals could integrate music therapy into routine pediatric care without major financial investment. Reduced PRN medication use could lower costs and improve safety. Enhanced engagement and satisfaction could lead to better recovery experiences and potentially shorter hospital stays. But perhaps most importantly, we'd have an evidence-based, low-risk, child-centered intervention that addresses both the physical and emotional aspects of pain. This aligns with larger movements towards holistic, patient-centered care and with the Institute for Healthcare's Improvement's triple aim: improving patient experience, improving population health, and reducing costs. For me, this isn't just an academic exercise. I've seen firsthand how difficult it is for children to cope with pain in the hospital and how that distress affects their families and the staff caring for them. I've also seen how a familiar song, a rhythmic beat, or a soothing melody can change a child's demeanor in moments. If one song can reduce fear and pain for one child, imagine what it could do for hundreds or for thousands of children. Thank you so much for taking the time to listen to my presentation and for your dedication to advancing the quality of care we provide to our patients. I appreciate the opportunity to share my Capstone project with you, and I hope that the information presented has provided insight to how music therapy can make a meaningful difference in pediatric pain management. Thank you.